Greetings, colleagues. The title of this presentation, Endodontics and Trauma Management in the Age of Implants, has been chosen because it is timely to discuss issues relating to these decision-making processes at this stage in the evolution of dentistry. I'm Geoffrey Heithersay. I'm Clinical Professor in Endodontics and Dental Traumatology, Faculty of Health Science, School of Dentistry, University of Adelaide, South Australia. So let's have a look at the common ground. First of all, it's obvious that if a tooth is non-restorable. Secondly, if there are vertical root fractures, as we see in this combination of tragic dental consequences. I've classified various degrees of invasive cervical resorption in a publication in 1999, going from a class 1 through to a class 4. Class 1 to 3 categories are treatable. The class 4 extraction is recommended. Where the arrows indicate the extent of this resorption. And in this case, without any other symptoms, no treatment is suggested, but ultimately implant placement will be required. An example of bleaching-related invasive cervical resorption features we can see outlined are, first of all, there's been a gross access cavity cut. There has been removal of gutta perca well below the cemento-enamel junction area, which with the bleaching solutions then has produced the basic cervical resorption on the distal aspect. Have a look at other forms of invasive cervical resorption. Here is a patient with a history of trauma some 9 years earlier who, after orthodontic treatment, showed an invasive cervical resorptive defect on the mesial aspect of her left lateral incisor tooth. And here we see a radiograph of this lateral incisor tooth 25 years after its original treatment. And here we see it 26 years later, two retained endodontically treated teeth with no signs of any resorption. Fibrous connective tissue in between the two fractured segments. Thank you for accessing this online presentation, which I hope will prove of value for your future treatment planning decisions.